Bueno, buenas noches y bienvenidos a nuestra sesión ordinaria del Colegio de Otorrinolaringólogos y Cirujanos de Cabeza y Cuello del Estado de Jalisco. Gracias al doctor Omar por permitirme coordinar esta sesión. Y pues, antes de iniciar, quería decir que vamos a dar, en vez de un par de conferencias, pues vamos a iniciar con una conferencia que se va a ampliar por parte del doctor Babak Azizzadeh, ya que él pues nos aceptó la invitación en vivo y pues le vamos a extender el tiempo. Vamos a iniciar presentando al doctor Babak. Él es otorrinolaringólogo por parte de la Universidad de UCLA, con una especialización en cirugía plástica facial por la Universidad de Harvard. Es director del Centro de Cirugía Plástica Facial Avanzada en Los Ángeles, California, y del Instituto de Parálisis Facial de Beverly Hills. Es pionero y experto en el tratamiento quirúrgico de la parálisis facial, autor y coautor de diferentes libros, entre los que destaca el libro del nervio facial. Y pues para nosotros es un honor presentar en nuestro colegio al mayor experto a nivel mundial en el tratamiento quirúrgico de la parálisis facial. Y pues con este tema que es cirugía de reanimación facial, que pues es de gran interés para nosotros. Pues bienvenido, doctor, y muchas gracias por aceptar nuestra invitación.
Thank you so much. Can everyone hear me?
Sí.
Okay, thank you. I want to thank the ENT Society, Dr. Chavez, for inviting me. I'm so sorry I couldn't be with you and enjoying your amazing company and maybe having a tequila together, as Dr. Chavez says, but hopefully in the very near future we can be together. So I'm gonna share my screen. Today, what I am going to talk about is surgical and treatment management for patients who have had facial paralysis, have had a recovery, and now have synkinesis. This is an area where, when I was training at UCLA and at Harvard, it was an area that we really would have only one option, which would be tell the patients, congratulations, they've had recovery from Bell's palsy or acoustic neuroma or Ramsay-Hunt syndrome, and go enjoy yourselves because your face has returned tone, maybe not great smile. And then very gradually we started doing a little bit more for these patients, but didn't realize how much of an impact synkinesis had on individuals. I have no relevant disclosure. And to start with, I want to kind of go over what an ideal smile is, because I believe everyone deserves to have, an ideal smile if they can achieve it, which for me is a smile that's spontaneous, natural, emotional. I don't think patients should be thinking about their smiling. They shouldn't be conscious of it. They should just be able to smile. And to achieve this, we need the corners of the mouth to elevate symmetrically, the oral commissure. We need to have symmetrical nasolabial folds. We need to have symmetrical dental show, both the upper and lower teeth. We want this to be the same timing, and we want it to be cosmetic and beautiful. I truly believe that aesthetics, form, function go hand in hand. And in plastic and reconstructive surgery, for a long time, either surgeons and plastic surgeons or facial plastic surgeons have been either great reconstructive surgeons or great aesthetic surgeons, but they haven't brought it together to cosmetically enhance their outcomes. So some of the key smile muscles are the zygomatic major and minor and the levator muscles, as well as the DLI. When we're communicating, the lower lip depression to show the lower dentition is very, very, very important in terms of aesthetics. And if there is some level of dysfunction of the depressor labia inferioris, that can really impact a smile. So for me, I always think about how can I preserve or recreate the native ipsilateral neuromuscular pathway. That gives us the best opportunity for a natural and emotional smile. Whether it's someone with synkinesis or not, we always try to see if we can accomplish this. Most common cause of facial paralysis, Bell's palsy, is number one by far, which by definition is a facial paralysis that is of an unknown etiology. And so when it's a diagnosis of exclusion and we haven't been able to find any other cause, that diagnosis becomes Bell's palsy. And obviously we want to treat Bell's palsy initially very quickly and effectively with steroids, high-dose steroids, antiviral, and that tends to be the most common cause. Probably Ramsay-Hunt syndrome will, in due time, as we get better at diagnosis, will end up being the second most common cause of facial paralysis. And I don't know if today you guys have seen the news. Justin Bieber, who is a very famous Canadian singer, just was diagnosed with Ramsay-Hunt syndrome and a complete facial paralysis. And then we get into the congenital patients who have had acoustic neuroma surgery, temporal bone fractures, parotid tumor, and stroke, and Lyme disease. Now, regardless of the cause of paralysis, the most common type of facial paralysis is what you see. Either patients will have a complete flaccid paralysis, or they will develop synkinesis if their regeneration of their facial nerve was not complete or normal. And in patients with complete paralysis, their muscles are no longer functioning. And if the paralysis lasts longer than 2 years, the muscles cannot be regenerated and cannot be revived. And so these individuals typically present with browtosis, lagophthalmos, lower lid malposition, effaced nasolabial fold, droopy oral commissure, no activity of the lower lip or upper lip. And as you can see, the dentition is always asymmetric. So in these patients, our management for complete paralysis really falls into two major categories. If their facial muscles can be revived, that means their paralysis is less than 2 years and we have access to the facial nerve. We want to revive those muscles by coapting the facial nerve to either the masseteric nerve, hypoglossal nerve, a combination of those. If the muscles are completely atrophied beyond the ability to revive, then we have to introduce new muscle or perform a temporalis myoplasty. And we'll talk about these two very briefly, but you either introduce I introduce a gracilis muscle transfer or a temporalis myoplasty. I prefer a gracilis free functional muscle transfer that's innervated by a cross-facial nerve graft because that gives our patients an opportunity to smile, but sometimes a temporalis myoplasty is excellent. So this is a patient who had an acoustic neuroma, and during its resection, the patient developed complete paralysis, and the patient presented to me about a year later. So we were able to do a masseteric to facial nerve transfer to help her coapt her smile and facial nerve and regain her smile. We later on proceeded with some other cross-facial nerve grafts to help her get spontaneity. This is an individual who we could not revive the muscles, so we performed a gracilis free functional muscle transfer. I like using multiple paddles to this muscle transfer, and we coapted the nerve, the obturator nerve, to a cross-facial nerve graft. So we did this in 2 stages. We did some aesthetic work. We did some fillers, Botox, etc., to give her an improvement in her nasolabial fold, dental show, etc. This is a young boy who has Mobius syndrome. So we utilized the gracilis flap, but I've been able to, over the past several years, be able to utilize some of his own facial nerve function to give him spontaneity. And this is a young woman who I have a pro bono medical mission group that we go to Ecuador and Peru, and we've set up facial nerve centers there. And for her, she had Mobius syndrome. We did a bilateral temporalis myoplasty with some reshaping of her face to improve her aesthetic appearance and give her an ability to smile. Now, these results are superior to the prior generation of static slings and temporalis transfers and so forth, but they still don't achieve many of the components of what we had talked about with our natural smile, which is they get obviously improvement in the excursion of their oral commissure, but it's just not perfect. The nasolabial folds are not perfect. The dental show symmetry is not perfect. Definitely the timing, there's a delay even when we do a cross-face nerve graft. And conversationally, emotive-wise, it's not perfect. Cosmetically, it's also not perfect. Again, all of these are significant improvement, but for me, I'm always thinking, how do I do better? How do I get better? And these techniques were what we were using for patients with synkinesis. Now, we talked about majority of patients who are seeking treatment actually don't have flaccid paralysis. They present with synkinesis because Bell's palsy is by far and away the most common cause of facial paralysis. And should we manage synkinesis similar to complete flaccid paralysis? And that's what many of my colleagues around the country and world have been doing. And for me, this was a major, major problem, because when I was thinking about the cosmesis versus improvement in their outcome, putting a gracilis muscle or having them chew to get an improvement, it just didn't balance. So for a lot of these patients, I typically did not offer surgical management until about 10 years ago, when I started really understanding and thinking about these patients a little bit further. And so to understand this, I really had to kind of grasp what is causing these individuals to have synkinesis. So any form of nerve regeneration after an inflammation, which is what happens with Bell's palsy and Ramsay-Hunt syndrome, injury, which what happens with acoustic neuroma or temporal bone fracture, or repairing the nerves back together can lead to synkinesis. And basically, when the nerves are damaged and they have normal facial nerve regeneration, all the axons and all the micronerves are kind of going back to where they were supposed to go. And if that happens, then when someone is trying to smile, they get the zygomatic and the levators to get activated. They get a little bit of DLI activation, and they get a little bit of eye activation. But in patients who have aberrant nerve regeneration, like in synkinesis, these nerves are not regenerated normally, and they're crisscrossed. And again, we don't understand this perfectly. There's also some central components. There's some other factors, but for the most part, what we see is overactivation and simultaneous activation of a lot of different muscles. Like in this case, this patient is trying to smile on the left side, and there's overactivity of the DAO, of the mentalis, of the orbicularis, of the platysma. So all of this leads to synkinesis, and there's a tug of war on the side of the synkinesis. So the treatment options for synkinesis we go to a neurologist today, it would be nothing, maybe some neuromodulators. Neuromuscular training is very important. And now, for me, surgery is extremely important. Now, the most accepted surgical treatment options for synkinesis around the world has been to increase power, like for patients with complete facial paralysis, because that's what we have gotten good at or had gotten good at. And the increasing of the power includes gracilis, nerve transfer, upgrades like the masseteric facial nerve transfer or temporalis myoplasty. And again, for someone with complete paralysis, this is great. But for someone who has synkinesis, it may not be necessary because the underlying issue is not one of power. It's one of lack of control and overactivity and tug of war. In fact, these individuals have too much activity going on, not too little. So reducing activity of these antagonist muscles, to me, is the key. So synkinesis gives us a unique opportunity. These patients do not have true muscle paralysis. They have innervated smile muscles. It's these antagonist muscles, the counterproductive, overactive, and uncoordinated muscle activity that prevents appropriate smile mechanism. And peripheral facial nerve branches are present and accessible. So the paradigm shift in patients with synkinesis is that if we can reduce but not completely eliminate the activity of the depressor anguli oris, the platysma, the mentalis, and the buccinator, while preserving the zygomatic, the levators, the DLI, we can enhance the smile mechanism. So that's really the key to improving these individuals. And in fact, neuromuscular retraining really is focused on that. It's relaxation and decreasing the tension on these muscles. Chemodenervation, such as Botox, has also been successful, but really for the eye and platysma, they've been really successful. The reason they're not as successful for the smile is because the antagonist and the smile, key smile muscles, are overlapping. So every time we try to get some of these antagonists knocked out with Botox, we end up actually knocking out the zygomatic and the levators and the DLI. DAO resection and muscle resection is really great as well because DAO is really pulling down the corner, but it doesn't impact the mentalis, the platysma, the buccinator. So it has a very limited improvement. And that's where neurectomies come into place. Peripheral facial nerve branches are present and accessible. We can precisely isolate and reduce the activity of the peripheral nerve branches to the antagonist muscles while preserving the nerves to the productive smile muscles. And it became a game changer. And basically, starting about 10 years ago, I started performing what I call modified selective neurectomy or selective neurolysis. And we've published our data in multiple peer-reviewed journals, which we've shown improved outcomes, improved smile, improved quality of life, and very quick outpatient surgery, same-day surgery, quick recovery. So the concept is very simple. We use a facelift incision. We selectively perform neurectomies to denervate the platysma, DAO, buccinator, and mentalis. We preserve the neural input into the key smile muscles, the orbicularis oculi, and the orbicularis oris, and the DAI. And sometimes we'll even reroute some of these nerves into the zygomaticus muscles to get some increased improvement. We oftentimes go ahead and do DAO and platysma resections as well. So this is our incision. We do this, again, just like we would do, the incisions are very, very straightforward. We do a subcutaneous dissection. Then we'll enter the deep plane and go into our SMAS, and subplatysmal plane, where we will start identifying the platysma as well as the nerves that go into to the buccinator, to the DAO, to the mentalis. All of these nerves are identified and tagged, anything that we're going to go ahead and transect. We stimulate, we show the video, we look at ourselves like this is a nerve that's impacting the DAO and bringing the lip up. So that's a nerve that we don't like. That's a major, major important nerve that we need to transect. This is a nerve that's to the DLI, so we preserve that because it's bringing the lower lip down. And we use a titanium clip to transect the section of the nerve. And so let's look at some results. These are patients that only had the selective neurectomy and nothing else. This is a patient who presented post-Bell's, and you can see everything's locked down. Corner of the mouth is going down when she's smiling. Lower lip is up, upper lip is down. We see no teeth. This is what we did for her, multiple nerves. This is her about a week later. And this is her about 3 months later. You can see her beautiful smile. She looks really great. And this is her about 10 months later. This is another young lady. You could see corner down, upper lip down. She has some dimpling of the chin. We see almost no teeth show. And this is her post-op. Really nice, beautiful smile. We're just asking them to smile big. This is not like, you know, they're not biting down, they're not doing anything. This is all spontaneous and natural, and we see 3 additional teeth all the way. This is someone who has severe synkinesis, corner of the mouth, totally locked up. Look at the corner being down. And this is her after surgery. We did not do a static sling. We did not do a muscle transfer. This is just her own natural tissues and muscles working better. And you could see her smile. This is a series of patients who had surgery and Botox for certain areas. This is a young girl who had severe synkinesis. Look at the upper lip down, and her eyes are narrowed. We see a lot of gum on the other side. Only 2 teeth on the right side. So we did a selective neurectomy. We also did some Botox around her eyes and around the left levator aliquot nasi, and this is her afterwards. So really good elevation of the upper lip. We see more symmetry, and we see 4 teeth. I've also published on something we call modified selective neurectomy with symmetrical facial repositioning. And basically, this is essentially doing some facelifting, buccal fat pad repositioning to create more symmetry, aesthetic improvement for the patients. This is someone who had had synkinesis for 25 years as a result of a gunshot wound to the temporal bone. This is her after surgery. You can see a soft smile, big smile. Dental shows even lower lip. That lower lip isn't going up as high. This is another person. You can see pre-op. Normal side is moving well. The contralateral impacted side is really locked down. And this is her after. Really good dental show. Lips are moving well. We see great upper and lower teeth. This is the video. And I try to show you guys videos because videos are really important. This is another person with moderate synkinesis. We did a symmetrical facial repositioning with selective neurolysis. You can see the banding is gone. The neck is improved aesthetically. I've also described something called a synkinetic unilateral lower lip palsy. A lot of people thought if the lower lip doesn't move down, then it's paralyzed. I described how no, there's no, it's synkinesis. The DLI is not paralyzed. It's just overactivity of the mentalis and the orbicularis that's causing the lower lip not to come down. This is a patient who had good oral commissure elevation. Look at the lower lip, how high it was. And she had had some digastric transfer at a very, very well-known facial nerve center. and she just like had deformity and couldn't smile well. So we performed a selective neurolysis. We basically took out the digastric, and look at how beautiful she looks. Her smile is much more improved, and she just looks amazing with better dental show. This is another person who had been seeing me for a long time. Look at that lower lip. Her smile is good. Her corner of the mouth is moving up. She has good dental show, but it's this lower lip that's elevated. And under normal circumstances, we're like, oh, you're paralyzed on that side. But no, I'll show you how she's not paralyzed. And we were able to improve her big smile. Look at the lower lip coming down now, her oral commissure, and I'll show you her video. And now we see dental show on. And look at her smile. It's a beautiful soft smile and big smile. And look at that lower lip depression. That's really important. I've also described just recently on how people who have synkinesis, who have brow dysfunction, it's different than someone who has a flaccid. It's also because of overactivity of the corrugators and the orbicularis, and we can help improve that a little bit. This is a patient, not perfect, but this is a patient who could not move her eyebrows, and we did a selective neurectomy of the nerve to the corrugator, which now I'm able to identify really nicely. Typically, there's a couple of them. Look at the difference. I mean, this is a pretty significant difference in her brow elevation from pre-op to post-op and position of the eyebrow. We've also been able to do this for patients with bilateral synkinesis. This is someone who had repeated bilateral Bell's palsy, and look at, I mean, she just like was miserable. I was scheduling her for gracilis. This is one of probably the second patient I did this for, but instead of doing bilateral gracilis to the masseteric, we did the selective neurectomy, and look at just how beautiful her smile is. It's not perfect, but she just now can actually open her mouth. The dimpling is gone, and she looks really good. This is a young lady who got mono and got bilateral facial paralysis from Epstein-Barr virus. Very, very rare. And this is what, about a week after her surgery, just unlocked it, improved her function. I mean, her life completely changed. And look at how many teeth we see. And this is the video. Now, about 10 to 15% of patients, I'm not satisfied with the results. And I recommend going back to the operating room and doing a little bit more. This is one of those patients. So this is the pre-op. So she's pretty locked down. Eyes, smile, everything's locked down. So we did a selective neurectomy, and this is her post-op result about a year later. So pretty good improvement in the dental show, but it's still locked down. Lower lip is still up, not perfect. So we went back and did a revision, and this is her after the revision. And look at how much better. We got a couple of extra teeth. The lower teeth look good. We can see them all, and this is her static. I mean, big change. So postoperative recovery, this is about 1 week after. Patients do pretty well, recover pretty quickly. It's an outpatient procedure, and recovery is really, really, you know, very, very nice and limited. This is someone who had selective neurolysis and symmetrical facial repositioning. This is a 1 week result. But the final result, some people don't get this. This is really, really good. Some people need about a year, year and a half to see the final results. And I do encourage postoperative neuromuscular retraining and stretching exercises and so forth. And longevity has been really good. This is someone who is, this is a 1 year result. She was coming in for Botox. That's what the dots are. And this is her 5 years later. So really good long-term results. So my experience, again, this is a single stage outpatient procedure. The most common thing that we see is temporary oral incompetence, which is expected. We've never seen it permanently. About 10 to 15% of patients will also experience kind of B's and P's being different. Revision rate is approximately 10 to 15%. It's just to go back and do a couple of nerves, see if there's anything that we missed. And I put that gracilis muscle transfer in my hands, about 30%. This is something that most patients who do, most doctors who do gracilis will tell you. about approximately 30% of patients will need a revision when they have gracilis. So 10 to 15% is acceptable. Patients, again, will get chemodenervation, neuromuscular retraining, and psychotherapy as needed. I've now had almost a 9-year experience with about 280 patients actually now. My initial study was published in a Plástica and Reconstructive Surgery journal. We showed statistically significant improvement by blinded observers in E-phase and House-Brackman, as well as the need for decreased Botox use. Subsequent study we published in the Facial Plastic Surgery and Aesthetic Medicine journal showed long-term statistically significant improvement in patient-reported outcomes. And we're just about to submit our 5-year follow-up that shows statistically significant improvement in the patient-reported outcomes. And the smile analysis is really good. Patients have really symmetrical improvement in their smile oral commissure excursion. They have more symmetrical laugh lines. They have symmetrical teeth show. It's symmetrical timing. And it's spontaneous, natural. And the conversation, the way that the lips move doesn't change a whole lot, although recently I've been able to identify these little teeny branches to the orbicularis oris that I'm preserving, and I think that's improving that. And aesthetically, patients look really great. And very few, if any, and really there are no facial reanimation techniques that achieve all the components of a natural smile. The entire neuromuscular pathway of a natural smile is preserved. So my algorithm, what I call an emotional algorithm, how do we get an emotional smile? Really, if the, from an ipsilateral side, if we can do a primary or cable nerve grafting, that's the only way we can get an emotional smile. And selective neurectomy gives us the ultimate way of getting that emotional smile. From a contralateral perspective, we can always, if it's available, in Mobius patients it's not, but in most people, we have a contralateral, we can do a cross-face nerve graft. And non-emotional smiles are masseteric transfers, temporalis myoplasty, and hypoglossal facial nerve transfer. So in summary, there's a paradigm shift, I believe, in the treatment of patients with synkinesis, downgrading signal rather than upgrading. And the modified selective neurectomy is very safe and effective outpatient facial reanimation that significantly improves spontaneous and emotional dynamic smile and patient-reported outcomes. These are some of the literature. I've actually just published a book with Dr. Nduka, who is a colleague in London, on the management of post-facial paralysis with synkinesis. I have also published all my surgical techniques for facial reanimation with Quality Medical Publishing, QMP, that was just published last year. And a few years back, Dr. Slattery from the Hauser Institute and myself published a book on just the comprehensive facial nerve. So that's the end of kind of what I have to say. I'm happy to answer any questions that there's out there and share any other thoughts. By the way, this is my email. You could always reach out to me and my Instagram. So anytime anyone has any questions about facial reanimation, rhinoplasty, or facelifts, I'm always happy to discuss. Those are the 3 things that I really focus my attention on.
Bueno, pues muchas gracias, doctora Azizzadeh. Una gran ponencia. Y si alguien aquí del auditorio o de la sesión virtual tiene alguna pregunta, pues el doctor está encantado de contestarla. Bueno, doctor, a mí me gustaría preguntarle cuál es el protocolo de los pacientes con síndrome de Mobius, cómo inicia su abordaje en el tratamiento. No sé si me escuchó, doctor.
Yes. What was the question? It was about Mobius. Would you mind just translating it into English so I could better understand?
Bueno, ¿cuál es el protocolo de tratamiento en pacientes con síndrome de Mobius?
Okay, so what's my protocol for Mobius syndrome patients? Okay, Mobius syndrome is a super exciting field for me right now because I think we have really missed some amazing opportunities because the majority of Mobius patients have some persistent facial nerve activity that is going into the platysma and the DAO, like that young kid that I showed you. So if I see that activity, I perform a bilateral gracilis free flap with coaptation of those nerves to the gracilis muscle. And that gives us an amazing opportunity to getting, again, I want emotional smile as much as I can. If those are not available, then my two options are using bilateral gracilis muscle transfer to masseteric nerve or performing a bilateral temporalis myoplasty like what I showed you guys, which really works extremely well. Both are very good. I think both are excellent. Obviously, the temporalis myoplasty is a little bit faster and quicker and more predictable, but I like both. So I will either use the gracilis muscle to their own ipsilateral nerves, or I will go ahead and use a temporalis myoplasty.
Otra pregunta, doctor. En pacientes con sinquinesia, desde un inicio, ¿les ofrece la cirugía o inicia con algún protocolo de Botox para ver cómo se van sintiendo los pacientes?
Okay, so I want to make sure, I think the question is, for patients with synkinesis, do I offer surgery at first or do I first go to Botox and physiotherapy? Okay.
Así es.
So when I started over the last 20 years, it's changed significantly. I think by the time someone has reached my practice, they have gone through their otolaryngologists, they've gone through maybe a couple of plastic surgeons that do this, and they are obviously suffering from this significantly. For the most part, I don't believe that with Botox and physiotherapy, I'm able to improve the smile significantly. So I always, not always, the majority of time recommend a multimodality treatment of surgery, Botox, and physiotherapy, and actually psychotherapy, because a lot of them have significant trauma, emotional trauma. So, and not always, but I would say I don't shy away from offering surgery at the beginning because those patients tend to be very, very, very happy and satisfied because this surgery is not like doing a temporalis myoplasty or gracilis flap or a cross-face nerve graft. It's outpatient, quick recovery, low risk, and exceptional outcomes.
¿Hay algún tratamiento especial para los pacientes que no pueden, o sea, como detener la comida mientras están ingiriendo los alimentos debido a la severidad de la parálisis facial? No sé si planteé bien mi pregunta.
Is that about drooling or problems with eating after facial paralysis?
Así es, y también se refiere un poco como a la comisura labial, ¿verdad?
So for patients who have immediate acute facial paralysis, who have drooling, obviously eye issues, things like that, those are patients that we really try our best to actually utilize steri strips and other modality to tighten up the lower lip, help their lower lip stay up, and not have as much drooling function. But it becomes very, very difficult to really control that in those first few weeks of the acute paralysis. And sometimes you have to do surgical intervention. But for the most part, it depends on what their etiology is. If it's an acoustic neuroma, that the nerve was cut, then we're going to do things differently than someone who's Bell's palsy, who we know the nerve is going to regenerate and the patient is going to get their tone back.
¿Alguna otra pregunta?
Doctor, en su opinión, ¿cuál es el momento clave de intervención quirúrgica en un paciente con parálisis de Bell de larga evolución?
So the intervention time, typically speaking, I like their paralysis or synkinesis to be stable. What that to me implies is at least a year and sometimes longer, depending on if they continue to see changes in their synkinesis, we'll keep observing them. So I don't like doing surgery on, can you guys hear me?
Sí, así es.
Yeah, so we don't proceed with surgical intervention until the synkinesis and paralysis are stable and not change. For patients who have had, let's say, acoustic neuroma, maybe they've had a temporal bone fracture, maybe they've had post-mastoidectomy facial nerve paralysis, very, very different. If their muscle tone has not returned, if they have no movement at 6 months, those are patients that we want to go in and do our hypoglossal facial nerve transfer. We want to do the masseteric facial nerve transfer. I'll oftentimes do a cross-facial nerve graft for them to try to get some spontaneity. So we want to revive and restore the muscle activity as soon as possible. Studies have shown that the earlier we intervene, the better the outcomes are. So there are two categories. One is what we know to be permanent, and two, what we know to be synkinesis, and they're going to be treated very differently.
Cuando hace, doctor, una cirugía para alguna reanimación de la parálisis facial, ¿qué tan frecuente hace un facelift del lado contralateral?
So the question is how often do I go to the opposite side to do treatments on the opposite side? Yeah,
Así
so
es como facelift.
yeah, often. I like bilateral surgery on facial paralysis patients because they age differently. Their facial tissues, soft tissues are different between the two sides, whether it's synkinesis or flaccid full paralysis. And in older patients. In younger patients, not much because their tone is really good. But in older patients, I am a big fan of doing bilateral surgery. And that's what my publication was on symmetrical facial repositioning. We often do that for parotidectomies. Like my colleague and I, Dr. Larian, we do a lot of parotid surgeries with preservation of the facial nerve and muscle transfers and so forth to create symmetry. And we'll do bilateral symmetrical facial repositioning to create symmetry between the two sides.
¿Existe alguna otra pregunta? Bueno, doctor, nos hubiera encantado que estuviera aquí con nosotros. Esperemos que en algún otro momento pues, pueda venir hacia acá y le agradecemos por su ponencia. En nombre de todo el colegio, muchas gracias.
Thank you so much. Muchas gracias por todo. I hope I was able to effectively communicate, I think, what I'm so passionate about. And I look forward to seeing everyone and meeting everyone in person, hopefully in the very near future, if Dr. Chavez invites me again.
Gracias, doctor.
Muchas gracias por todo.